This session is based on program planning in public health. And a lot of times when people are planning programs, they do not stop to think about the process. And so today we're going to talk about the process and a few models and how they relate to planning. So I'd like you to stop and think about where you should begin to plan when you're planning a program, writing a curriculum, developing a training, or writing a grant. And those are often really hard to think about. So instead, think about what is the very first thing you do when you plan a vacation. Typically, when you plan a vacation, you plan the end first. Where are you going? Where will you end up? And that's exactly how you plan anything if you're going to do it the most effective way. So as you're writing your grant or you're planning the program for this class, you're going to need to think about where will you end up. And in the grant, it gives you your goals as to where you end up. Just to put this in perspective of vacations, if you were going to plan a vacation, the very first thing you would decide would either be the purpose of the vacation, why you're doing it, or where you're going. So if, for example, the purpose of your vacation is to learn about a culture, that's going to determine where you go. Where you go is also important because if you were going to Greece, you would plan a completely different vacation than if you were going to Yosemite Park or if you were going to Alaska. So as you're planning your program in this class, remember to think about how important it is to determine what that last piece is, where you will end up or where you're going. So what's on the screen right now is the actual image of the precede-proceed model as it was originally developed. It's often difficult to read in this format, so we're going to look at it piece by piece in each of the phases. However, the key point of this slide is whenever you see this diagram, you should know you're looking at the precede-proceed model. So in the precede-proceed model, there's various stages, and the very first stage is social assessment or the quality of life. In this phase, you're looking at the quality of life of your population, and you're assessing the overall social elements. So for example, what is the quality of life on a reservation of Native Americans or American Indians? What is the quality of life of someone living in rural USA? What is the quality of life of someone living in poverty? What is the quality of life of someone living in an urban setting? So you're looking at overall quality aspects of someone's life. In phase 2 of this model, you're looking at epidemiological data or the health of a population. Epidemiological data typically includes morbidity and mortality data. What is the incidence of the condition or disease? What is the prevalence of the condition or disease? And what is the mortality rate of the condition or disease? When you're doing the epidemiological data, you will find that there are disparities in the data. So a population might make up 10% of the population, but make up 30% of a disease category. Or two populations might have the same incident rates of a disease, but mortality rates are different in one of the races or groups. These are all really important aspects of epidemiological data, and they are critical when you're planning a program because you're going to use that data to show there's a need for what you're doing. In phase 3 of the precede-proceed model, you're looking at behavior and the environment. And as we get to phase 3 and 4, some authors put the phases together, some authors do not. We're looking at the precede-proceed model as it appears originally from the authors or the creators of the model. So as you're reading through your texts or materials, you may find that some of the phases are blended together. But in phase 3, we're looking at behavior and environment. And there's two elements that impact epidemiology. One is the behavior and lifestyle of someone, and the other is the environment. So in behavior and lifestyle, if we think back to some of the same examples, what behaviors or lifestyle aspects in a reservation of American Indians would impact their health? What behaviors or lifestyles in rural USA would impact someone's health? What are the behaviors and lifestyles and how they're impacted by poverty? How would that affect someone's health? Or if someone lives in an urban setting, how does their behavior or lifestyle differ from others, and how does that impact their health? Some examples would be substance use, eating patterns or eating behaviors, physical activity, smoking, whether people smoke or not. These are all examples of behavior and lifestyle that might impact health and might be different in different settings. The environment includes the type of things like, are there more chemical toxins in certain environments? Is there more pollution in certain environments? Do certain jobs cause different risk factors than other jobs? So it is where a person lives and works and plays, that's the environment, and then their behaviors and lifestyle. As you can see on the slide, behavior and lifestyle interacts with the environment, and they all interact with health and epidemiological data. The next phase is called educational and ecological assessment, and this is one of the most important phases of the model because this is the phase that is most often talked about, and that is predisposing factors, reinforcing factors, and enabling factors. Predisposing factors are those factors that your population comes with. So, for example, what are their existing behavior and lifestyles? What is their environment? Are they obese? Do they live in poverty? What racial makeup or ethnicity are they? Those are all predisposing factors, including genetics. What's their genetic makeup? Are they predisposed to certain conditions? So these are things that people come to you with. So as you think about your community will have predisposing factors that are there when you start your program. Reinforcing factors are those factors that are reinforced by society or community, family, and peers. So for example, if you're raised in a family that eats a lot of fried foods, that's a reinforcing factor for poor or unhealthy eating habits. If you are raised in a community where there's a lot of substance abuse or violence, then you're more prone to substance abuse or violence. If your church or synagogue or mosque or any other religious affiliation encourages certain types of behaviors that are reinforced, that's an example of how culture could reinforce behaviors. And the list goes on, but these are all aspects of society that reinforce or encourage certain types of healthy or unhealthy behaviors. And the last part of this phase is enabling factors. And enabling factors are typically one of two things. They are either availability of services or accessibility of services. So if services are available, so for example, you're on campus and there's a campus health center, that means the services are available to you. But accessibility is more complex. So for example, are the hours of the health center appropriate for you as a college student? If you live on college campus and the health center closes at 3 or 4 o'clock in the afternoon, is that really accessible? What about the cost? What is the cost of health services? What if the costs are really high and you don't have health insurance? If something is right down the street from you, but you cannot afford it and you do not have health insurance, that means it's not accessible. So, enabling factors include mostly availability of services and whether or not they can actually be accessed. Another example of this would be travel distance. So, if you live in an urban area and something is 5 miles away, you're either going to take 2 hours to walk there, or maybe it's an hour and a half to get there through public transportation. Again, it's there, it's not accessible. The same would be true as accessibility issues in rural areas. If something is 25 miles away and there's only one vehicle in the household, it's not likely you're going to be able to get to where you need to be in relation to health services. Oops, excuse me. In phase 5, you're looking at administrative and policy assessments. There are policies and regulations in organizations and in cultures and societies, communities that regulate what you can and cannot do, or what health behaviors are encouraged or not encouraged. And then there are health education programs that can occur in this phase. And at the bottom of the chart is implementation of your program, and then process and impact evaluation and outcome evaluation. These terms could vary based on the model you're using, but in the Precede Proceed model, outcome evaluation is related to phase 1 and 2 at the top, and it's related to long-term outcomes. So what are the outcomes in quality of life, and what are the outcomes in epidemiological data over 5 or 10 years? Impact evaluation is related to phases 3 and 4, and that is right after you do an intervention. What does the evaluation tell you? And process evaluation is also related to phases 3 and 4, and it's related to the processes you're using to do your programming. And so this is what the Precede Proceed model looks like. Another model that's really important in the field of health is the health belief model. And this is a more difficult model for a lot of people to understand because it talks about the beliefs or perceptions of your population, not of you. So all of us are in the health field. Our beliefs about what's important are different than the regular average person. So, for example, does your population believe it's at risk? And I'm just going to choose a couple topics for substance abuse. Is your population living in a community with high substance abuse rates? And if they do they see that they're at a greater risk for substance abuse? If they see that they are more likely to develop substance use disorder, then their perception of risk is different than if they don't believe they're at risk. And that determines what happens in your program. The next item is severity. How severe does your population think an issue is? Do they think that substance use disorder is severe enough to change their behaviors? Do they think that the results of diabetes is severe enough to change their behaviors? Do they feel that sexually transmitted infections are severe enough that they would change their behaviors? So the risk, do they believe they are at risk for it? And then how severe do they think the condition is? The next item is what are their perceived benefits, not your perceived benefits. So for example, as a health person, your perceived benefit might be that if people stop smoking, they're less likely to get sick. If people eat healthy foods and exercise more, they're less likely to be obese and more likely to be healthy. That's your perspectives on benefits. That's not necessarily the perspectives of your population. Knowing what your population sees as a benefit is critical to developing effective programming. So, for example, in certain cultures, family is more important than in other cultures. So if you're dealing with a culture where family is important, A benefit would be that if they stay healthy, they're around longer for their family members. Or if they participate in your program, a benefit could be is they get coupons for supplies or services they need. So you must figure out what they think benefits are and then incorporate their perceived benefits into what you're doing. Perceived barriers are again what they think are barriers to the behavior you want them to do. So, for example, if you want them to exercise, what do they see as a barrier to exercise? Not what you see, what they see. What do they see as barriers to not using substances or to not smoking? What do they see as barriers to purchasing healthy foods? It's important for you to understand what they think the barriers are because your programming should address those barriers. Later after the health belief model was developed, a decade or so later, perceived self-efficacy was added to this model. So self-efficacy is the belief that someone can do what you want them to do. And if they think they can do what you want them to do, they're more likely to do it. For example, do they believe they can quit smoking? Do they believe they can participate in exercising? Do they believe they have the skills to cook and eat healthier foods? It's important that they believe they can do what you want them to do. If someone believes they can do it, they will try it. If someone believes they cannot do it, they will not try it. And then cues to action that refers to your programming. Finally, it's important for you to look at your grants and think about these two models, the Precede Proceed model and the Health Belief model, and to start to think about how you can incorporate those models into your program planning.